large hospital here. So it is a very exciting time in colorectal surgery. The advances that are coming out almost monthly, both in chemotherapy, immunotherapy, surgery, and radiation. And there's a lot of options for patients now, so it is a very exciting time. Today I'm going to talk briefly about total neoadjuvant therapy. Should it be the standard? And the short answer is maybe. So there has been an evolution in rectal cancer treatment, and we've been in an era of treatment escalation. Starting 50 years ago, where surgery was the standard, the addition of radiation either before or after surgery, then the addition of chemoradiation, and then adjuvant chemotherapy, to now, all the way on the right, you can see trials looking at total neoadjuvant therapy. So I'll talk a little bit about that, the results, and where we go from here. Well, if we turn the calendar back 50 years ago, this was the biggest problem with rectal cancer treatment. And anyone who has treated rectal cancer knows what this is. This is a local recurrence. It is not curable. It's associated with terrible morbidity for the patient. And the best treatment is prevention. Now, 50 years ago, on the right of the screen, the rates of local recurrence were almost identical to distant recurrence, both about 25 to 30%. So initial efforts were to reduce local recurrence, and that's where studies using radiation before or after surgery really had a dramatic change. The curves show local recurrence with surgery alone, again, representing almost 30%, which can be brought down to about 16% with long course chemoradiation, short course, I should say, radiation, either long course postoperative or preoperative short course. The addition of chemoradiation, that is 5-FU as a sensitizer with radiation, brought local recurrence rates further down to about 10–12%. These were dramatic improvements, almost very rapidly, which changed the face of rectal surgery. However, it was the German rectal trial that looked at preoperative chemoradiation versus postoperative chemoradiation. And for the first time, local recurrence rates were brought less than 10%, somewhere around 5 to 6%, a dramatic improvement. However, we still had an issue of distant recurrence. Although we reduced local recurrence, distant recurrence rates remained stubbornly high at around 30%. Now, the distant recurrences are the result of micrometastases that are present at the time of diagnosis and take 1, 2, 3, or 4 years to develop into clinically apparent metastases. Now, these micrometastases are very sensitive to systemic chemotherapy, and if we extrapolate from colon cancer, we would expect a 50% efficacy of chemotherapy eradicating micrometastases. That's what we see with adjuvant chemotherapy for colon cancer. We reduce distant metastases rate in half. So why are we not seeing any benefit in rectal cancer treatment? And this has been an area of intense investigation. The cooperative group EORTC 22921 is a complex trial, 4 arms, but I'm just going to pull a little piece of the data there. This looked at postoperative chemotherapy, and 60% of patients did not receive the prescribed chemotherapy, and over a quarter received no chemotherapy, likely because they never fully recovered from chemotherapy on time to receive that treatment, were too infirm or sick, or had a complication like a leak that prevented them from getting the chemotherapy. And it's for that reason that we started to give the chemotherapy up front, and that is really the beginning of the idea of total neoadjuvant therapy, where the chemoradiation and the chemotherapy are given before, and surgery is consolidation treatment. So you can start with chemoradiation and then chemotherapy, or the reverse, chemotherapy and chemoradiation with surgery as the last step. We reviewed our experience 2009 to 2015. We started using total neoadjuvant therapy quite early. And just from this study, we looked at the group of patients that had chemoradiation surgery, chemo, the traditional approach, versus those that had total neoadjuvant therapy. And indeed, patients were much more likely to get the prescribed 5-FU or oxaliplatin if it was given before surgery than after, with much less dose reduction. However, it was only recently that larger prospective randomized trials proved that there was an improvement in oncologic outcome, either disease-free survival, metastases-free survival, or even overall survival. And we should look at these. The Rapido trial was a prospective randomized trial of advanced bulky distal rectal tumors, T4 tumors with EMVI, multiple lymph nodes or involved mesorectal fascia, or lateral nodes. Patients received short course radiation with consolidation, Capox or Folfox, and then surgery, versus the traditional chemoradiation surgery plus or minus adjuvant chemotherapy. And this trial indeed showed an improvement in what they called disease-related treatment failure, as well as metastases-free survival. The follow-up 5-year results confirmed this data with improvements in distant metastases-free survival from 30% to 23%. Overall survival was not different. However, very interestingly, there was an increased local recurrence in the TNT group, and this may be related to the short course radiation and possibly difficulty with surgery. This is an area of active debate. The Prodige 23 French trial looked at T3 and T4 rectal cancers and randomized them to the triplet FOLFIRINOX, 5-FU, irinotecan, and oxaliplatin, followed by chemoradiation surgery and additional chemotherapy, to the more standard chemoradiation surgery plus or minus Folfox. The problem, of course, with this approach is that you're comparing a triplet to a doublet, so you're changing multiple things. But in the TNT arm with the triplet, there was improvements in disease-free survival and metastases-free survival that were quite impressive, with hazard ratios of about 0.64 to 0.65. The 7-year results again showed consistent and persistent improvements in disease-free survival, but most impressive, improvements in overall survival. And so this really was the first time that we're seeing the result that most of us look at, overall survival and improvement in TNT, or total neoadjuvant therapy. Absolute improvements, 7.6% for disease-free survival, absolute improvement in overall survival of 6.9%, metastases-free survival almost 10%, cancer-specific survival 5.7%. The last study I'll bring up is the Stellar trial. This is a slightly smaller trial, also locally advanced rectal cancers, T3, T4, node positive, treated with short course radiation, Capox, surgery, and more Capox versus chemoradiation surgery and Capox. And here there was, it was a non-inferiority trial. And this trial showed us that both arms were equivalent for disease-free survival, but there was an improvement in overall survival in the TNT group. This is a little bit funny to look at. Part of the reason is the non-inferiority design to look at disease-free survival. So if we put these in a table, We have the entry criteria, the study name, the entry criteria, the endpoint, either 3, 5, or 7 years. And you can see that if we're looking at metastases-free survival, there was improvement in TNT and Rapido and Prodige. Disease-free survival, again, Rapido and Prodige, there was superiority in the TNT arm. Overall survival improvement in the TNT arm in Stellar and Prodige. However, there's also another interesting finding, and that is pathologic complete response. The TNT arm had improvements in pathologic complete response in all 3 studies. And these were somewhat dramatic, almost a doubling of the pathologic complete response rate. This brings up the idea of watch and wait, active surveillance, or rectal preservation. Probably the best data comes from Julio Garcia Aguilar's trial, the OPRA trial, which was specifically designed to look at watch and wait. It was a phase 2 trial that compared 2 arms to historical controls. Patients, and it was a sequencing trial. They compared induction FOLFOX chemotherapy to chemoradiation, and they compared that to chemoradiation and consolidation chemotherapy. Now, what was different about this trial, and really I think quite remarkable, is that at the time of evaluation of clinical response, patients were categorized into 3 groups. Complete response, which is shown up top, which shows scar, no evidence of disease. Near complete response, which reveals some irregularity. So a very, very good response. Maybe this is progressing to a complete response. And then incomplete response. If you had an incomplete response with clear gross tumor after total neoadjuvant therapy, you went on to surgery. If you had a complete or near complete response, you were recommended to have watch and wait or observation. The TME-free survival, that is the ability to have organ preservation, was about 50%. This is the highest that's been evaluated, and I think this is because we included near complete responses. Again, that group can go on to incomplete response or complete response. And if you give them time, you will find out which way they go. We'll talk about that a little bit later this afternoon. Now, interesting, the sequence of chemoradiation and consolidation chemotherapy had a better chance of rectal preservation compared to chemotherapy and chemoradiation. This was actually followed up in a German trial with similar results. So, if you're interested in watch and wait and organ preservation, total neoadjuvant therapy gives you the best opportunity for that. So if we compare complete response, this can be pathologic or clinical. With short course radiation, it's very rare because it's 5 times 5 with immediate operation. Chemoradiation, it's usually about 18 to 20%. Short course radiation with consolidation chemotherapy, with that delay, you can bring up the rate of complete response to about 25 to 28%. But when you use total neoadjuvant therapy, especially if you're going to give chemoradiation and consolidation chemotherapy, the clinical complete response rate was 60% with organ preservation. So does TNT meet expectation, and should it be the standard? Again, possibly. It does increase compliance with prescribed chemotherapy. It improves disease-free survival and overall survival. It facilitates watch and wait and rectal preservation, but treatment escalation has increased treatment-related toxicity. So this is an algorithm that we use at Memorial Sloan Kettering, and it's really patient-specific. You have to bring into the conversation what the patient is looking for. So for instance, if you have a bulky upper rectal cancer, but you don't have an at-risk circumferential margin, upfront surgery is a very good option. This is the study Okum where they compared upfront surgery versus treatment and then surgery, and they were equivalent. If you have a mid-rectal cancer, locally advanced, chemotherapy and then surgery is a very good option. You avoid the toxicity of radiation, and this is the PROSPECT trial, a 1,000-patient trial that looked at chemotherapy and surgery with the use of radiation only for those that didn't respond, and over 85% responded. However, if you have a low tumor and you require an abdominal perineal resection with a permanent colostomy or a very low anastomosis, which is associated with poor bowel function, then total neoadjuvant therapy is the best option. If you have extensive lymph nodes or EMVI, then the Prodige approach with the triplet makes sense. However, chemoradiation and consolidation chemotherapy does currently have the highest rate of clinical complete response and rectal preservation. So some of it depends on the patient. So for instance, a younger patient, a female patient that wants to preserve fertility, chemotherapy and surgery is an excellent approach to avoid radiation that can alter fertility. And again, on those very, very low tumors that require a permanent colostomy, then chemoradiation and consolidation chemotherapy is the way to go. Thank you very much.
Thank you very much, Professor Weiss. Any question from the floor? Okay. If not question, we can keep the question because we still have the discussion in the case. Yeah. Thank you very much. Yeah. Then our next topic is circulating tumor DNA. It's one of a very hot topic in recent year. And today, our lucky to have Professor Manop Pitak-Phakon, a well-known medical genetician at Sirat Hospital. Professor Manop, please.
Good morning, everyone.